be discussing a pediatric delirium intervention known as the BRAINMAPS algorithm. As a brief review, the definition of delirium is most simply put as acute brain dysfunction. Delirium is a behavioral syndrome which results from critical illness and or the iatrogenic factors involved in treating that critical illness. Its characteristics are that it has an acute and fluctuating course and is defined by disturbance in attention or awareness, in addition to cognitive dysfunction in the realms of memory, orientation, language, and perception. Importantly, delirium is not due to another underlying neurocognitive disorder. A recent point prevalence study found that 25% of pediatric ICU patients suffer from delirium. Additionally, we know that pediatric delirium typically occurs in the first 1 to 2 days of hospitalization and is about 1 to 2 days in duration. So now that we know that about a quarter of pediatric ICU patients suffer from delirium, but it's typically early onset and short-lived, and we haven't recognized it for years, why should we care and what is the significance? The significance is that delirium is associated with worse hospital outcomes and out-of-hospital outcomes. We know from recent studies that pediatric delirium is associated with an increased adjusted length of stay, longer duration of invasive mechanical ventilation, and even increased mortality with an odds 4-fold greater than patients without delirium. Additionally, adult literature has shown that a single episode of delirium in the ICU increases your risk for subsequent delirium, anxiety, depression, delusional memories, and post-traumatic stress disorder. You're probably familiar at this point with the Cornell assessment for pediatric delirium. This is a rapid screening tool which takes less than 2 minutes to administer and has a 94% sensitivity for the diagnosis of delirium. It does not distinguish between the different subtypes of delirium, in particular hypoactive versus hyperactive versus mixed type, but there's an important note to be made about the hypoactive subtype of delirium. A recent adult study in 500 adults with either respiratory failure or shock found that hypoactive delirium was much more prevalent than hyperactive delirium. Additionally, when they did cognitive and executive function screening 3 and 12 months after discharge, they found that those patients with hyperactive delirium had an association with worse cognitive and executive function, while those with hyperactive delirium did not have the same association with cognitive and executive dysfunction. So, this is important because while hypoactive delirium is more prevalent, it is typically less recognized, and so this screening and intervention is crucial for these patients. A tool used to combat and treat and diagnose delirium has been presented and is known as the BRAINMAPS algorithm. This is based upon a philosophy put forward by Dr. Traube and colleagues, which suggested a 3-pronged approach when a patient tests positive for delirium. Firstly, we would like to investigate for any underlying illness which may be precipitating delirium, evaluate any iatrogenic causes, and then try to modify the abnormal environment of the ICU if possible. This algorithm has been used in several different large centers and has been relatively successful. Here is the BRAINMAPS algorithm in its entirety. On the left, you'll see a column outlining the letters which stand for different assessments and etiologies for possible new delirium. B stands for bring oxygen. We know that delirium is associated with states of hypoxemia and low cardiac output. So when a patient becomes delirious, it's important for us to assess what their oxygen delivery is. You can titrate oxygen support if appropriate and discuss screening for anemia and transfusing red blood cells if clinically appropriate. Next is R, which stands for remove or reduce drugs. So we know that delirium is associated with particular drugs including anticholinergics and sedatives, especially benzodiazepines. So if appropriate, it's always important to discuss discontinuation or reduction of precipitating drugs if possible. Next, A stands for atmosphere. So the bedside nurse has a lot of autonomy in terms of room setup, and so it's important to critically evaluate how we can make a room more familiar and more orienting for a patient who's at risk for delirium. The use of restraints has been associated with the development of delirium, so discontinuing restraints where appropriate is always helpful. Employing the presence of a family member or caregiver can certainly orient a patient and help them if they are becoming delirious. Establishing a care schedule or routine is good in terms of keeping patients oriented to their surroundings and their time. And then, if they're not able to communicate effectively, use of adaptive equipment where age appropriate is always helpful. These are recommendations for other ways to normalize the ICU environment, which I'll let you evaluate on your own time. Next, I stands for infection, inflammation, and immobilization. We know from several studies that there is a infectious or inflammatory hypothesis for the development of delirium. And so any infectious or inflammatory state may precipitate new onset of delirium. When a patient becomes delirious, it is always appropriate to pursue an infectious workup. Next steps would be treating fever and initiating antibiotics if appropriate, as this may severely help the development of delirium. Secondly, I stands for immobilization. So there's good literature that shows that early mobilization, as clinically appropriate, can drastically improve the duration of delirium and the severity of delirium. So employing colleagues in physical therapy and occupational therapy is always helpful for these patients. Next, we have N and M, which stand for new organ dysfunction or metabolic disturbance. Delirium can sometimes be due to a new organ dysfunction such as CNS, cardiovascular, pulmonary, hepatic, renal, or even endocrine dysfunction. So if a patient develops new delirium, it is important to critically evaluate if there's a new organ dysfunction, this can be attributed to. Early steps that a nurse can take would include normalizing electrolytes and considering if there's a new primary neurological disorder, such as encephalopathy, encephalitis, or seizures. Next, awake. So delirium can be attributed to poor sleep hygiene, so it's important to try to limit disturbances of the sleep-wake cycle and establish a bedtime routine if possible. If it is at all possible, there's a lot of benefit to clustering care at nighttime and working on sleep hygiene with clustering and batching sleep and having age-appropriate naps during the daytime as well. Next is P, which stands for pain. We know that delirium can stem from either undertreated or overtreated pain. So when a patient becomes delirious, it's important to critically evaluate their analgesia and discuss whether any adjustments are appropriate for either decreasing or increasing the amount of pain medications they're receiving. Additionally, looking at etiologies for pain is a critical part of evaluating a patient's risk of delirium. So we like to critically evaluate their need for daily invasive tubes and lines, such as chest tubes, Foley catheters, and central venous catheters. Finally, S stands for sedation. So patients who receive benzodiazepines have been found to be at a higher risk of developing delirium. So whenever a patient is on benzodiazepines, it's important to discuss if this is crucial for their treatment plan, and if not, we can talk about weaning or discontinuing those as appropriate. If a patient still requires some element of sedation without analgesia, dexmedetomidine has found to not be associated with the development of delirium as opposed to benzodiazepines and can be employed as appropriate. So this is the BRAINMAPS algorithm as outlined. Please use this slideshow as a reference, and you'll have this resource at your fingertips as well. It's important to recognize that using this and our CAPT screening tools, you do have the tools to treat delirium and to improve our patients' outcomes.